PowerPoint as well too, Phil, when you have a chance. That'd be great. Great, thank you. Well, wonderful. Thank you all for joining us today. And I just wanted to take a moment to talk about our purpose for our meeting, and I have the agenda on the next couple of slides here, but I want us to switch our thinking from it being a traditional webinar where Cammie, Rhonda, and I are going to talk at you for an hour to more of a discussion, a work group, so to speak, for the purpose of developing our measurable outcomes for our project, both from a site-specific standpoint and for the project as well, so we can continue to, or so we can gauge the progress of our objectives, of our activities to meet the objectives, and also begin to tell the story of our journey through this project as well too. So, so keeping that in mind, casual environment this morning. I want to hear from you, Cammie, and Rhonda want to hear from you as far as ideas that we're exploring and so forth. So I just wanted to set the stage on that.
Yeah, and so this is Cammie. Hello, everybody. Thank you for joining. The purpose of focusing on developing measures and helping to tell your story is that this is the information that's going to help craft the why of why we're focusing on integrating behavioral health, and this is going to demonstrate our impact, and this is going to be excellent material for you as you're looking for future grant opportunities or funding opportunities to show that we are making a difference in the work that we're doing today. So just keep that in mind as we go through today's session.
And I'm really good at calling on people if there's silence on the other line to help facilitate our conversation. And so yeah, and it just as a brief reminder, as Rural Health Innovations is a subsidiary of the National Rural Health Resource Center, and we are funded through a grant from the Office of Rural Health and Primary Care through Minnesota Department of Health as well. So our agenda today and our purpose, we mentioned briefly around that is, again, collaborative discussion, really thinking through how we want to look at measuring some of the work that we're doing from a process standpoint and from an outcome standpoint as well too. So we're going to do that by talking about that each site will have site-specific measures that they'll develop, but there'll be some standardization across all of them. And as we go through some of the slides here, you'll see why that is, but we're not set in stone on what those measures will be yet. We really want to talk through our outcome evaluation process with you. We had to, as I'm sure you guys are aware in writing grants and things like that, write an evaluation process of our work and the project's work and the hospital's work. So we're going to share with you what that is and how we're visioning that at this point. And then we are providing an example of a data sheet that could help track measurements and outcomes going forward too for some feedback and review as well today. Nyla, thank you for your question. We will send out the PowerPoint after for sure. Yep, we will. Because it's got a little bit more detail in it too in regards to our conversation and of areas, and we will be providing notes of decision points that we've all come together as well in this after as well. So we'll send both of the notes and the PowerPoint out. First, I'd like to just, go ahead. Are you all muted? Are we all muted? No, you guys should be able to talk, Lori. I asked Phil to unmute the line, so each line should be not muted. You can mute from your phone specifically if you're having some background noise or not, but please speak through the phone line and or the chat box. Any other questions as we get going today? What I would like for us to do is go around and introduce ourselves. We got together back in May with the folks in the participant list on the left-hand side, and then we've since then have each had a site visit with each of the hospitals in their communities. So, Cami, why don't you, well, you've talked already. Rhonda, if you could please introduce yourself.
Sure. I'm Rhonda Barkus, and I work with RHI, and I'll be doing the follow-up for you all later around the outcomes from your project.
And let's just go around. I'm going to go down the list on the participant list. Angela, if you could just please state your name and your organization as well.
This is Angela Knowles, and I work at the Sanford Laverne location as a triage therapist.
Thank you, Angela. Jessica?
Hi, I'm Jessica Stokes, RN, Mental Health RN at First Light in Mora.
Great, thank you. Lana?
I'm Lana Barenwald. I am the clinical supervisor at Sanford Clinic in Laverne.
Thank you. And Laura?
Hi, Laura Ackman. I'm the Chief Operating Officer and Administrator for the Essentia Health Northern Pines campus in Aurora.
Thank you. Lori?
I'm the clinic director for Laverne.
Thank you. And Nyla?
I think Nyla may be on.
Mute. Okay.
Well, you have to call in to be able to talk.
Yeah, that is true. We did set up a phone line for this. Tammy? Or Trent?
Yep, I'm the health coach at the clinic in Laverne.
Thank you. If we can go to the next slide of the visit. And just to set the stage, a brief reminder, since it's been for some of the sites, we were there in mid-July, and we just finished the Essentia Northern Pines Aurora yesterday. But our vision for the project is, as you know, we're providing whole person care through the integration of behavioral health with our hospital, clinics, and behavioral health providers and communities. And what I'd like to point out is
Can I interrupt?
Yes,
This is Jan Carr. I'm online too.
Hi, Jan.
Hi.
Are you logged in on the webinar?
I called in.
Okay. Just an FYI, in the meeting invite, we do have a webinar link. We have some slides that have some talking points up that we'll be using for our discussion today.
I'm trying to get to them, and every time I hit it says it's a MIME attachment. Is that correct? Does that make sense?
Let's see, Phil, does that make sense?
Kicks me out. Kicks me out every time I try to go to it.
Okay.
But that's all right.
No problem. We'll get slides to you as well, and we'll be very vocal about what's on them and what we're discussing.
Okay. Thank you.
Tammy's on as well, by the way. I finally dialed in so you can hear me.
All right, Tammy, thank you.
Thanks for the heads up that we had to dial in.
Yeah. We've been exploring using the calling features through Adobe, but we're not 100% proficient yet. So we supplement with the phone line, the conference line. So like I mentioned, we just finished our last site strategic planning visit yesterday in Aurora with Laura and in her community in Aurora, Minnesota. And what we saw through the theme of all of the site visits and this is a summarized version of our project goal. Each community has a specific take or a little bit better detail that's specific to their community, but in essence, the goal of the projects being developed and the collaboration being built is to decrease emergency department visits for people in behavioral health or social crisis through better outpatient coordinated care. So that's a summarized version of each site of what everyone's, I think, overall intention is in this project, but there are some specific nuances. And as we're providing each site with the documentation of their site visit or their strategic planning visit, we put that specific goal that was refined in, I think it's the first or second page of there as well. So you can reference that. And Laura, we'll get your information out to you by the end of this week from our discussion yesterday. So is there any thoughts or comments in regards to this overall goal? Did we state that correctly in general?
This is Jan. I definitely agree with that.
Okay. And Jessica stating she agrees as well too in the chat box. Great. So in our May workshop, we talked a bit about, and in some of our site visits, about identifying operational and organizational processes that each hospital and their community will address. And just in a brief summary, the process that we did at each site visit, the strategic planning, did that in its essence to address this. For example, an organizational process or working collaboratively with other types of providers in the service area to improve transitions of care, and that was the event, the strategic planning day. Using data to improve health and safety of patients. Many of your organizations brought emergency room data to share with the community in regards to how many you're seeing per month, who's bringing them in, where are they going, how long they're taking of your staff's time in regards to those that are in acute crisis. Operational examples are initiates collaborative meeting with behavioral health resources in your community. And so some of you have started subgroup meetings that you're doing already in creating a resource directory that identifies all of the resources available in your community. And our discussion today what I want us to focus around is collecting that clinical or utilization measures related to behavioral health to see how we're implementing and progressing along the way and for those lessons learned. And so I just wanted to kind of build off of how we've designed our technical assistance and our approach to say that we are doing that in the steps that we are. You've identified those in your activities and that lead up to those objectives of meeting and addressing the gaps in healthcare that you've identified at each of your planning days as well. So Rhonda, and the evaluation process that I spoke about briefly at the beginning of our call is the process that we reported to MDH that we would do. And I'm going to hand it over to Rhonda now to just kind of talk through the concept or our process that we will do and that we'll start talking about today. Rhonda?
Sure. Thank you, Alyssa. So we've used this project or this process for other projects. We created it for other projects. It's been really successful because one of the things that we feel strongly about is that measurable outcomes are a piece of the story, and we want to make sure that you all have the opportunity to tell the entire story around your project. And so our outcomes evaluation process includes both. It includes some measurable outcomes, and it also includes the story to go with the measurable outcomes. But we also feel real strongly that it's important to keep the measurable outcomes to only a few, so you're not going to be asked to submit 20 measurable outcomes, which I'm sure you're quite thrilled about. But we're really just going to pick the few that are going to make the biggest difference. And we will talk about those in just a little bit. So our process includes the measurable outcomes and then what we call the recommendation adoption progress, or we call it a RAP. So the RAP is a phone conversation that I will have with your team in probably about 12 months after you've had your on-site visit. So we're looking at about 12 months for most of you guys. So for about this time next year, I will contact you. We will set up a phone call. Whatever leaders you want to include in that, you can have in the meeting. And generally, it takes about 30 minutes. There are some specific questions that go along with it. It's like 5 questions that will really be around discussion, and I'll send those to you in advance. But the discussion is really just going to be me facilitating that conversation about your project, what's been going well, what are your next steps. So it's really an opportunity, again, to tell that whole story aside from just the measurable outcomes. And then it also focuses on the accomplishments, not just the measurable outcomes. And so we'll also talk about some of the ways this project has, in non-measurable ways, impacted your community, your hospital, your staff, et cetera. So it's really a nice, complete picture. And then I pull all that information, and that's what we present. So that's the wrap process that you'll hear us talk about. And again, that'll be about 12 months.
Are there any questions on that?
This is Jan. I just have a comment. I do not have our grant manager sitting here with me today, but if I could have her be added to the email or the meetings that are going to talk about that, because she is the one on my end that will kind of coordinate that piece of it.
Okay, that sounds great. So Jan, and we will follow up with you to get that, to get her contact information to make sure that we have that as well. Any other folks, so hearing about this process, with what Jan said, which is a great point, are there any other people that you may want to help join with this discussion? Not today, obviously, is a little bit late in joining, but going forward too. We can pause right here to think that through, or we can send a global email out to our main contacts asking for that information as well.
So maybe folks could send you some emails for folks they want added. Would that work? Mm-hmm. And then, and then when it comes time to do this outcomes discussion, there will be one point person who will pull all the members together that will be part of that 30-minute conversation that I'll have with you. And that's totally up to you, whoever you want to invite.
Okay. Thank you. Any other questions in regards to the evaluation process? And maybe they'll naturally come up as we move forward too.
This is
and
Lori
actually,
in
go ahead, Lori.
One quick question. When you said this is what we'll present, who are we presenting to?
Well, when I say
that is. Oh, go ahead, Rhonda.
Oh, sorry. When I say that, that's when normally what I do is I pull together kind of a summary of the entire picture, and then that's what I share with our team. And then at this point, usually for the other projects, we have to share that with whoever the state partner is or the project officer that supported the project. So sometimes those folks see that. And then beyond that, I mean, that's kind of, I think, up in the air just a bit as far as other ways that you all or we might want to use that. Alyssa, what were you going to say?
Sure. I was just going to expand a little bit beyond that, too. Another project that Rhonda and I are working on where we've done this process, we've been asked with a community to present at NRHA. It's the National Rural Health Association's annual conference because it was a unique collaboration and they were seeing some results. Cammie, did you want to expand a bit beyond that?
Yeah, and I think this is about telling the story, the journey. So there's no right or wrong, or if you aren't able to meet those metrics that are set forth, that's totally okay because this is a pilot program and we're here to learn what works and what doesn't work, and that's part of the process. Mm-hmm. So it's just outlining our processes.
Mm-hmm. You know what, and I'm glad you said that, Cammie, because a lot of times when I've done wrap interviews for other projects, they haven't, they've only implemented a piece of the project. They're not, everything's not totally done. And so sometimes the outcomes aren't totally met yet. And that's why I like to get the rest of the story, because that helps them to say, well, okay, we haven't met this outcome yet, but look at all this amazing work that's being done behind the scenes that's moving us in that direction.
Yeah, and so part of that story that Rhonda solicits is helping you to identify that if you're maybe feeling a little bit bummed out that you haven't met those objectives or metrics that have been laid out, she will say like, oh, well, you know what, we had to start further back and maybe look at collaboration, and making those first steps in collaboration take so much time and effort, and so that's the first point in your journey. And so maybe that's telling your story about focusing on collaboration with your community, for instance.
Yeah, and I promise you, this is the least intimidating and scary outcome story you'll ever have to tell. I promise. It's, in fact, most people when I do it afterwards, they're like, oh my God, I didn't realize we did so much work. And so it's, yeah, so it's really kind of actually motivating and enlightening. So I promise you it's not going to be painful.
Yeah. In fact, Rhonda she's so good at what she does. We've had other sites call her up even 2 years, 3 years later saying, hey, Rhonda, I just wanted to tell you. And they initiate the same RAT process because they're so excited to share those outcomes and share more about their journey and what they're doing. And so from here, because we have a national perspective, we'd love to hear that information and then disseminate that, showcase that nationally, and showcase the excellent work that you're doing. So it's a vetted process that has been very well received by all who have participated.
Any other questions or thoughts? Okay. So this next slide, I'm going to come back to it after some further discussion that we have, because as I was reflecting this morning, this is more of a slide that we have some jets going by right now, so I apologize if there's some background noise. This is more of a discussion maybe after we have our next couple of slide discussions. But one area that we are seeing with our common goal that we identified at the beginning of this project is that there's a common theme to decrease emergency department visits for the population, the behavioral health population that's using it. And so that just is that is a common theme. So I'm just going to go forward to our next slide, and we'll come back to that. So in our evaluation process, I'd really like us to think about and discuss, these are ideas on the board here, but some common metrics that we can have at that we're going to look at from each hospital and community perspective across the board, and then there can be some site-specific ones as well too, but we would like to see a common metric, I guess. And so some of the options that we've been floating around here based on the data and the discussion that we had with each of y'all at your strategic planning days is ED visits. You know, do we want to look at a way of tracking the total number of ED visits for the target population that each of you have defined? Emergency department visits by unique individual. So we know, and sometimes we have repeat offenders, you know, or high utilizers, and so decreasing from 10 visits in a year to 3 is a huge outcome win. Another aspect that we've talked about too is the cost perspective of utilizing the emergency room versus using more outpatient type services as well. And these aren't defined yet, but we're wanting to bring these forward for discussion with the group here. And then just the total cost in general that the behavioral health utilizers that are in acute stress are using as well too. So looking at maybe some type of measure for total cost as well. So I'm just going to pause, let that sink in. And then the measure of your choice we'll talk about in a little bit too, what those areas will be. This isn't a all or nothing list. These are just when Rhonda and I got together a couple weeks ago when I was sharing the themes that were coming out of our discussion site visits. These are ones that have come to mind to me and to Rhonda in some of our previous work in lives that we've done.
This is Lori Jensen. Laverne's had a lot of discussions about all of these, and I think they make a lot of sense. The only concern we had was that For instance, to get our baseline information, Nyla had to actually go in and do chart reviews on a sample population because our physicians were not routinely using a diagnosis that we could pull data, that was necessarily a behavioral health diagnosis. So I think we've talked about if we could train them to consistently use, give us a set of diagnoses that we were going to be able to pull and use as appropriate those diagnoses, but I think that would have to be, for us anyway, part of the first step of capturing it. We wouldn't have apples to apples comparison.
Okay.
And I'm thinking that might be actually part of the story that you'll tell too, that we didn't even have these measures up front. So part of it was putting that, this is what we did to put it into place, and then we started gathering these pre-project measures.
I mean, certainly there are some patients where that's the only reason for presenting, and yes, that diagnosis is used, but there are others where the underlying is the behavioral health, and they may not capture that necessarily in the visit diagnosis.
That's a good point in regards to, and that can go into our discussion of, the data criteria, the data pulling methodology. Do we look at just the primary diagnosis of them presenting in the emergency room, or do we want to go down to that that second, third chief complaint or that diagnosis that brought them in? And because I don't know that would be unique just to Laverne. I think, in thinking about some other discussions with other sites, that is not a unique situation. Other thoughts?
This is Jan. I'm definitely agreeing with the comments that are being made. I know in my chart review that I have on my list, I asked for MRON numbers for obviously depression, anxiety, suicide, but also, overdose. And, when I think about this, I think, man, so many of our people that are coming in for pain medication, really the secondary thing, and I didn't ask for those because then you're going a whole nother direction. But clearly there's other people that present with more of the medical thing where the physician's probably not putting any kind of a mental health diagnosis. They might be putting chronic pain, but how many of those folks would it be good to capture?
Right. And and that's a good question, Jan, too. I know when we've looked at some of this baseline data across the sites, it's been just like the primary diagnosis. We, in one site particularly, we didn't pull any of the substance abuse or the drug overdose codes as well, that more just focused on depression and anxiety diagnoses. And that goes back to our discussion around when we started talking about the target population at our planning days, is that as we're having these discussions and thinking it through, having that very specific criteria of who we're working with and the goal that we want to get to with that population as well, too. And so, and age is a very specific criteria of that as well, too, but this diagnosis code piece is huge.
I think it's fair to say, especially in the clinic world, we've done a lot of work on chronic, disease management and registries, and the state even driving the Minnesota measures of, well, what CPT codes do we pull, and ICD-10 codes, and that's all, I think, very possible. But I think that's right, it's part of the story. And long term, if we're to develop some kind of a patient-by-patient report that shows us this patient has been in 5 times in the last 4 months for behavioral health issues to the ER, we're going to need our providers to consistently give us that information. We can't do it by a physical chart review. So I do think that doesn't necessarily exist today, but it is kind of a fundamental of what we need to do to go forward.
Any other, Jen, from First Light, I know there was a lot of, you had some nice reporting that you brought forward as well too, and I think we're all on EPIC, some version of EPIC as well too. All of the hospitals that are in this project, they're all on EPIC, and I know that means really different things. There's different versions, and it's being utilized in different ways too. So just wanted to say that out loud too. So as we're problem solving or thinking this through, and for other hospitals that may have addressed that that issue or that barrier, that to share that solution, or how you've done that well as well from an education standpoint. So, go ahead. Is someone going to say something?
Are these outcomes feasible to collect data on? Is it going to be easy, realistic?
With that question, I want to also point out is that we don't need to do all four of the, all of these ones. And so what would be more manageable to begin with? Because this one, the utilization one, whatever we decide on, I would like it to think about how it could be consistent across all projects. So let's think about or talk about what would be realistic.
Trying to gather everybody's support and figuring all this out so that we're consistent. So it might take us a little bit longer than somebody who's maybe not dealing with a system that has to develop a standard report, because we have an enterprise data. So it may be a little bit more challenging on that aspect.
Okay.
So we'll do our best as we get this metric figured out, but I just want that that caveat known up front, I guess.
Yeah, no, I understand that. How about anyone from First Light? Any thoughts, Jessica, or in Jen from RC Hospital? Don and Olivia.
This is Jen from Olivia. I've worked quite closely with our data analytics guy, and he has developed a report for us. It's a nice report that we were able to pull from our transfers, actually. We looked at our transfers, and we did it by diagnoses, and we have a length of stay on there. We have if they were transferred, where did they go to, because a lot of that we were pulling manual. We did have to go in because we didn't have a report either, and so we were doing manual abstraction of that data, and that was taking a lot of time. And so we were able to now say if they were placed on a hold, who placed the hold, where did they go, their length of stay. And this was kind of developed by our task force group. We had our first meeting with you guys when you came on site, and that's the data that group wanted. So we have a good report for that. And I'm thinking, and this is just me not knowing data analytics very well, but I'm thinking the cost per visit and the total cost can be pulled into that report pretty easy too, because that's all in Epic, and it's all just another part of the information that's there. We just need to pull it in. And so when I'm done with this phone call, I was going to bring these measurable outcomes over to him and find out, like, can he get that built in the report too, or how easy is that going to be for him? Because really it's dependent on your report builders and your...
Exactly.
In a lot of places, like if we would have to, we have Epic, so if we would have to go through CentraCare St. Cloud to have this built, it would not be built yet. I'd probably be waiting another month or two. But our report builder here is phenomenal. He does really well. So he's able to pull reports for us that sometimes we don't have to wait for. But I know every place isn't like that. So I agree with whoever was talking before that this could take time for some sites. But,
Yep.
So I don't, did that answer your question maybe or no?
Yes, thank you.
Yes, and And I do understand the reporting and analytical, the timeline and challenges and things into it.
And there's a cost. I mean, a lot of facilities, there's a huge cost. If we would have had to have Epic build this would have, I think when they priced it, it was over $1,000 for this one report just to be built.
Gotcha.
So, you know, there's a cost associated with it if you have to use external partners to be building.
On that too, I would
yeah.
say, coming from Laverne, I think we need to look at that behavioral health diagnosis because that's very vague. So see, we're going to have that defined as far as
we broke ours down. We broke ours down.
This
to
is a diagnosis that we use, you know, so that we're it's going to have to be, well, on this site they chose these behavioral health ones. This site they chose these. Because if I would bring that to my person to build a report, they're going to say, well, what diagnosis codes do you want me to pull?
Right.
Yep. And we did that. We had him pull a few of them. Because our task force decided on a few of them. So we went with depression, anxiety, suicidal ideation. And then mental health eval. So those 4 are what he used to pull the report. He built those in.
Okay. And that's
what
a good
our task
point.
force wanted to start with. And our task force meaning our community partners. And that doesn't mean that we won't narrow it down at some point, but that's what this group initially wanted to start with, and then we meet again on Tuesday. On the 30th we're meeting, and then that's when I'll bring this information forward to them and see if they want to narrow it down by any diagnoses or age group or, I don't know, however we want to move forward.
And Jen, thank you for those points, and Lori for talking about the diagnosis challenges, because that is a good point, and that diagnosis does need definition. And but think about that in that it's a good clarification point. That doesn't need to be the same. That diagnosis definition does not need to be the same at RC Hospital and Clinic as it does at Sanford Laverne or at First Light and Mora. That diagnosis description needs to be specific to the population you're working with, like Jen shared that their task force wanted to focus on those 4 areas. And so that doesn't need to be the same across all 6 sites. It needs to be specific to yours. So that is a very good point in regards to needing to make.
That was Tammy speaking, by the way. This is Lori.
Oh, I apologize.
No, that's okay. But one thing that we at Sanford probably could build on, Trent, we need to look at the high-risk we have high-risk case managers in Sioux Falls that currently have a patient registry report, and it accomplishes that report accomplishes the one where we look at individuals and how often they are hitting the ER. And so we need to look at that report and see if we can tag into that, because, you know, that's a clear win. And if we don't have to be the same as every other cohort, that will help us. We'll just tag into that one. From a standpoint of pulling the data of number of ER visits specific to Laverne, I agree with Tammy that we're going to have to sit down and talk about what are the diagnoses that we want to pull and measure reduction in, and then how do we teach our ER docs and our folks that manage the ER to use those when it's appropriate to do so, so that we can be accurately measuring.
Just a clarification, Lori, it would be we teach the coders what to code, because the coders are the ones that do it.
Docs don't drop. They don't associate visit diagnosis?
No, on the ERs.
Okay.
So more of a coding question.
Okay.
So, coding question. Okay. So we're taking notes here as well too, and because I really appreciate this discussion this morning, and so what I envision is us providing in our notes that instruction, those tasks that are being identified here that will help clarify the coding or those next steps for each entity, and along with a timeline of when folks could think that they could present that back to us, you know, having that defined. knowing that to implement is going to be different stages for each community as well because of what we're hearing, education on coding and or the documentation aspect of it, and or if a report can be built to help support this work as well.
My only concern, Lori, again, is we won't have baseline data doing that because we aren't currently doing it. So, you know, our early data, first quarter maybe we report it by quarter or something, we can show progress potentially, but we won't have the baseline data to compare.
Yeah, and that's a good point. Thinking back to, or looking back to what Rhonda was talking about a bit ago too, is that's part of your story, you know, and when you look at some of the organizational processes that we put way back to February when you completed the assessment and or the application to participate, that is exactly one of the steps in that organizational readiness is utilizing data to make decisions or instituting those data processes for that. So that is a very clear, identifiable objective and or activity to help meet the goals of this project. So this is a very good learning discussion for myself that as much as we'd like to streamline and have everyone start at the same point, that's also not the point of this project as well too. You know, that each community we need to work where they're at and help them move along that continuum, and data is an important part of that.
Yeah, and this is Rhonda, and that's why we're not just looking at the data, we are looking at the whole story, because even the work on that is progress, and that's what we want to capture.
Correct. And as we've talked with MDH Will Wilson, he was at a couple of our site visits, and Judy and some other folks as well too at the federal office level a couple weeks ago. They want that story. You know, they of course everyone wants better health outcomes, lower costs, better patient satisfaction. Yep, that's a given. But I am not. In all of our discussions, we're hearing progress. You know, moving forward and documenting that, and that's what we're doing here as well.
I think the other really challenging piece as we look at cost is important, but measuring what is the real societal cost of that visit might be kind of tough. You know, does the crisis team have to respond? There's a cost to that. It's not part of Sanford. So some of the things might be harder.
I agree, and let me just go. Let's see here. So thinking about that, what we've dubbed the measure of your choice. Here are some different kind of categories as well too, because you're right. The societal cost, the societal improvement could mean many different things to different organizations and the people we're serving as well. And so we'd like you to think about, and this doesn't have to be standardized across all 6 sites as well too, but what is another measure or a process that you'd like to look at that can help show improvement in that societal bucket that you just mentioned? So in all of our visits with you guys, we talked about the time that not only hospital staff have, but law enforcement staff have in bringing people into the ER, having to stay with them when they're in such acute crisis, distress from a safety perspective. We've talked about staff satisfaction. You know, who wants to spend 8 hours sitting next to someone in a hospital when there's other education, there's other medical type stuff to do as well too. So these are, you know, some thoughts that we had in other areas that could be looked at as well too, as far as this project is getting rolled out.
This is Jan. If I can just interject a neat little story I just heard yesterday. I know you, the facilitators have heard our story, but I don't know about the rest of us. We have implemented a sitter program in our facility to help reduce nurse time sitting with that person that needs supervision in the emergency room, and also to reduce law enforcement time. Well, yesterday I had the opportunity to talk to one of the sitters, and her typical job is she works in our dietary department. And she was telling me that this is something that is bringing her such a sense of doing well and giving back to her community, the fact that she gets to go and provide that service in the emergency room. And I thought, wow, we talk about, the greater good for society, but here we're giving somebody this opportunity to do something that she'd have no reason to come across these types of situations. And just a sideline.
Yep.
Wow. Thank you for sharing that. That's beautiful.
So thinking about this measure of your choice, or we could think of a craftier, catchier title for it, but any thoughts in this area, or maybe Jen, have you thought any of looking at any measures in this area that with your task force yet, or thinking about that, or
does anybody have any other ideas for other measures like this?
Who did you say, Jan or Jen?
Jen, because I know they've had a task meeting, subcommittee meeting already, and are meeting again next week.
No, I guess, have we looked at how no, not really. I mean,
okay.
Right now we're kind of just focusing on who are we going to focus on, and
right.
What our strategy is. I guess the biggest thing that we're trying to do is manage them more in an outpatient setting instead of placing a hold and shipping everybody. And one thing that we are developing, and we're hoping to start the development of this on Tuesday, is kind of an algorithm or a resource guide, because what we're finding is that a lot of our task force members have so many services available that none of us knew about. So we're all able to utilize each other in some way that nobody really knew you could do that, or I didn't know you guys had that service, or I didn't know you could do that, or I didn't know that was an option for us or for the patient. And so we're going to kind of put together an algorithm or a resource guide for the nurses or the providers to utilize first, and kind of go down that avenue instead of placing a hold right away and shipping them somewhere. Last night we actually utilized one of our first services, and it worked really well. So
could you provide that example of what it was, just to give an idea?
We had a younger adult, a 19-year-old female, come in crisis. She was depressed, having some anxiety, and typically she's a repeat customer patient. She frequents our ER quite a bit with the same symptoms, and typically we place her on a hold and send her to a hospital for a few days, and then she'll come back about a month later. She frequents. And what we did this time is we called the mobile crisis unit. And they came within about an hour of the phone call, and they worked with her, and she was able to go home and then follow up with them today as an outpatient.
Wow.
Wow.
So that really helped, and that cut down costs for everybody, and it helped our staff. Like, it freed up our staff to not have to make hours worth of phone calls, and it was a new service line that we were unaware of, and so it's just nice that it was collaboration together. And so that was our first one, and I talked to the provider today that actually set it into motion. She said it was about an hour and 5 minutes from the phone call to when they came.
Wow.
So that was really nice. And so no, I guess to answer your question, I don't think we have any we haven't thought to, I don't know.
But you know what? There's one right there. If you could start counting the number of times people access those other resources instead of what you typically had done. I mean, that's
true.
I mean, your baseline was zero basically, because it wasn't even a known option. So from zero to whatever, that's huge.
So the number of times they utilized different alternative resources or alternate resources.
This
is Tammy. The one thing that I was thinking of even in Laverne is the number of holds that we placed on. I think enforcement and the county attorney, that's a big deal for them because that's a huge cost. So I was thinking that we could probably gather that data pretty easily because I would bet that they're tracking those. And then the other that would go in would even be a number of crisis intervention plans that we've got that are interdisciplinary with our community resources, because that was one thing we identified in our meetings was the ability to have that crisis plan put in place, that if there's a way for that crisis response team to even respond to the patient in their home instead of law enforcement nabbing them or bringing them in by ambulance to our ER and then just totally avoid us altogether. So those are some of the things that we've even noodled on in Laverne.
That's great. Those are great examples. Any other thoughts in this area?
We've had a little bit of discussion about whether there's any need for any clinical measures. In a different grant, we were chosen for, we tried to impact our depression scores in Minnesota, and PHQ-9 and GAD testing, and whether Angela felt there was any other clinical test that might be population management tools to try to predict crises and intervene before the crises. But I think that's probably phase 2, you know what I mean?
And I had written down that this morning as I was thinking about other examples too, because I know a couple of our sites talked about implementing a screening tool and that earlier identification of folks. And so another idea that came across my mind was, how many screening tools have you implemented, have you done? But even, that's another counting type measure. But a clinical outcome would be, having your population have a pre-screening to see where they're at it and when they're more of acute status, but then seeing them, that self-rating of those go down, as they're not as an acute mode, that they're more stable, and so they're not, I'm losing my word right now, but they're not increasing and then presenting in the ER or doing some of those things. But so that was another one.
We were pretty successful with that, actually, by increasing the number of patients we screened. The doctors then intervened more proactively, and so those patients were probably more aggressively managed on an outpatient basis, which hopefully and ultimately, hopefully, reduces your crises. So I do think it has a place for things. I don't know how much more we would tackle, because we are currently doing that. We're doing PHQ-9s on as a population on when they come in for a physical, and for our diabetics when they're in chronically, and then if there's a diagnosis of depression, we do the GAD-7 and the PHQ-9, and whether we would do more than that, I don't know.
Oh my goodness, we're at 11:57 already. I'm having fun. No. So other things, and go ahead.
I was just going to say, so it sounds like there's lots of options, and maybe even just we could start capturing some of those different ideas and shoot out to everybody, and as you guys have other ideas, send them to us, and then we can just keep kind of a list. But the ideas are pretty endless here.
Correct, and I think what the big task is, the elephant in the room, going back to our metaphor from yesterday in Aurora, is the biting off more than we can chew sort of thing, but is what makes sense for your project in your community. Right. And that we do need to narrow that down eventually. And so we'll think in knowing that the progress along that will be different for each community, but as long as we're capturing that progress and or those next steps, that's okay, at what level each community is able to do this. And so I've been taking notes. We've got this recorded. I'm sure Rhonda's been taking some notes as well, too, that will capture this up. We'll throw out some timelines of what our goals are, and when I say goals is what you want to work towards or explore, because do understand that commit to anything here. It's to get this conversation of evaluation and process started because we weren't able to get to it at our individual site visits with you guys.
Okay, so I think,
go ahead.
I think this is my slide.
Yep.
Okay, so just a few more things. The post-project measurable outcomes. We will be, of course, using the same measures pre-project and post-project. We will, when it's time, 12 months down the road, when it's time for your wrap interview, I will send you a data sheet, which you'll see in just a minute, where you're going to be able to go ahead and identify your post-project measurable outcomes. That way, when we have our 30-minute conversation, we won't be talking a lot about the measurable outcomes unless we really need to refer back to that. So that way, the interview is really going to be around collecting the information about the story. And then both of those, as I said earlier, are used to paint the entire picture of the measurable outcomes, but also what all went into making that happen. This is an example of what the data sheet might look like. On the left column, you can see the anticipated outcomes, like decrease in total emergency department visits for a certain population. And so then we will identify, so what is the measure we're specifically looking at? And then there will be a column where we will capture your pre-project data. So that's going to be as soon as we can go ahead and start get that baseline. And then at the wrap interview in 12 months, that's where we get the post-project values. And then we just look at any percentage and change. So it's just just as simple as that. Very easy to submit.
And
again,
Rhonda,
this will be somewhat individualized, of course. This will be somewhat individualized based on your anticipated outcome.
And this is Alyssa, and this is a tool that we've used for this wrap process that Rhonda talked about. But Cammie and I have also talked about, how can we help support each site moving forward and provide technical assistance and answer questions. And this, we're thinking about using this as kind of like a communication form tool as well, for periodic, the frequency of reporting, to see the progress being made and sharing that along the way. Because part of our evaluation process with MDH is we have to share that progress, where we're going, what we're seeing, what are some barriers, how we're tackling those, some aha moments. So this might be a way for us to start capturing that as well. I want to respect everyone's time. It's 12:01. Thank you, everyone, for joining in the great conversation and discussion and sharing today. We will write up our notes, and I've got some next steps and the ideas that were described here as